Hi, I'm Andrew Einstein, a cardiologist at Columbia University Medical Center in New York, and it's my pleasure to welcome you to Molecular Imaging Highlights from the American Heart Association Scientific Sessions in Orlando, Florida. The American Heart Association Scientific Sessions is one of the world's leading cardiovascular meetings. There are about 25,000 people here to share the latest news and advancements in cardiovascular medicine. And we're talking about some of the latest advances in cardiology medicine, and in particular, focusing on molecular imaging and molecular medicine. Frank, thanks for joining us today. I'd like to begin by asking you a very basic question. What is molecular imaging?
What we define as molecular imaging is based on the tracer principle. We use molecules, which we give at very, very small concentrations. We can follow those molecules because they're labeled with a radioisotope, which sends out radioactivity as part of its decay. So we can track that radioactivity with specific gamma cameras, which identify the radioactivity distribution within the body.
What is inflammation?
Inflammation is basically a response of the body towards damage of an area. This means the immune system of the body reacts to the damage by sending immune cells there, by activating local molecular mechanisms with the target to induce repair.
Why is inflammation important in cardiovascular disease?
Well, it's been learned in the last years that inflammation seems to be a key process in the development of atherosclerosis, but also in advanced stages of heart disease, such as in heart failure or in the response to myocardial ischemia. So, and again, inflammation there plays a role because the body is trying to repair the damage caused by atherosclerosis or ischemia or heart failure. But in many settings, we know that this doesn't really work appropriately anymore. And then the inflammation process itself contributes to progression of the disease. And atherosclerosis inflammation results in vulnerability if it's excessive inflammation. It also contributes to the progression of heart failure if it is exaggerated. And that's why people aim at inflammation nowadays as a therapeutic target, which is also the reason why we as imagers aim at it as a diagnostic target, so that we can help those people that try to modulate inflammation for therapeutic purposes by giving exact images of the state, the extent and the severity of inflammation.
What role does the imaging of plaques play in taking care of patients with atherosclerosis?
One of the things that molecular imaging is struggling with is visualizing very small targets, because the spatial resolution of molecular imaging, especially radionuclide-based molecular imaging, is limited compared to anatomic imaging, such as CT or MRI. They have higher spatial resolution. And because the plaque is so small, we're still sometimes struggling in visualizing and getting a clear image of the plaque. Now technology has been advancing over the last couple of years, and it seems to be better possible nowadays, but still we need a good molecular mechanism that provides high contrast in order to visualize a plaque.
How does a myocardial infarction or heart attack occur, and how can we image that?
The general notion right now is that you get myocardial infarction because an atherosclerotic lesion in a coronary artery is inflamed and is rupturing. Once the lesion ruptures, it results in thrombosis and occlusion of the vessel. Then the vessel is occluded, and because the vessel is occluded, there's no blood flow to the heart muscle anymore. The heart muscle suffers severe damage and it's basically dying. Once the blood flow is restored, we now know that heart muscle is still damaged and continues to suffer extended damage because inflammation is happening after the occlusion of the vessel on the heart muscle level. And again, if this inflammation is too strong, the process of damage may continue. And because the damage may continue, this is an additional target of therapy, which may be directed against inflammation in order to save additional heart muscle.
Here at the American Heart Association Scientific Sessions, you and your colleagues are presenting a very novel study which involves imaging the chemokine receptor type 4. What is that receptor and what is its role?
The receptor is called CXCR4. It's a specific chemokine receptor which is expressed on basically all inflammatory cells. And the whole goal of this assay is to target the inflammatory cells within the body. Our work has focused on using this kind of receptor ligand, which is radiolabeled, to identify the severity and extent of inflammation after myocardial infarction. Now we can do that because the receptor is not strongly expressed on healthy heart muscle. If that were the case, then we would get a mixed signal of inflammatory cells and myocytes and other cells within the heart muscle. But because the receptor is so specific to the inflammatory cells, we get our image that is strongly reflecting inflammation only. The ligand has been primarily used in oncology and in hematological diseases before, because it binds to hematologic cells, and because it also is expressed on some cancer cells. We were probably the first to do this work with this novel ligand in the cardiovascular system, but there have been other groups, including the group in Munich which developed the tracer, which used this in oncology primarily.
Mm-hmm. Are there any current or future medications which might be used to treat a patient who's had a heart attack, and which the decision about that could be made on the basis of this pentixaphore imaging?
Interestingly, and that is why this receptor is so interesting, there are small molecules available which block this receptor. So they can be used, and there are clinical trials ongoing which aim at using these small molecule blockers for therapeutic purposes.
What is the next step for pentixaphore imaging?
Right now we're doing follow-up studies in our patients in order to identify whether the imaging signal early after myocardial infarction really has a predictive value to predict whether somebody is at higher risk to have heart failure later on. And if that is the case, the next step for us, and the preparations are there already, is to really get into therapy trials, to use the imaging assay to guide CXCR4 target therapy, and to only give the therapy to those patients that have a strong signal coming from the myocardium. This is the whole goal of molecular imaging, actually, is that we identify a molecular target, and by identifying the molecular target, we help with guiding a novel molecular therapy to the right group of patients. This kind of principle is pursued in oncology already, where they have a lot of molecular targeted drugs. In cardiovascular medicine, we don't have that many, but the ones that we have, we can probably use best if we also use imaging to guide them to the right patients.
Are there other ways to target inflammation with imaging which might be beneficial?
I think there is a lot of different ways to target inflammation, and we still don't know the best way. It's part of the challenges of molecular inflammation imaging is that we don't have the perfect tracer to target inflammation yet. On the other hand, we also know that inflammation is a very complex process which involves a lot of different cells and a lot of different molecular pathways. And maybe we do not need the one-size-fits-all inflammation assay. Maybe it's more important to have a molecular imaging assay that targets the same structure or the same molecular pathway that's also being used for therapy. So whatever kind of specific molecular therapeutic agent we have, the best way to guide this molecular therapy in the future would be to have an imaging assay which looks at the same molecular structure. And the CXCR4 is a perfect example for this.
So it sounds like there's a lot more research which is needed, but this really has the potential to tremendously benefit patients who have heart attacks in the future.
And at the same time, in the long run, we also hope that we can use this imaging assay in heart failure, where inflammation plays a role, and maybe later on also in atherosclerosis, despite the challenges with the small target, but still it's an inflammation assay which we could also maybe use to look at atherosclerosis and help with novel therapies there too.
Well, this is really fascinating work, and I congratulate you and your colleagues for that, and it's really an important contribution to science for which you should really be applauded. So thank you very much, Frank Bengel, for joining us today.
Thanks, Andrew.